Oh. Testing 1 2. Testing 1 2. Testing. Testing 1 2. Can you anybody hear me? Yeah. Testing 1 2. Testing 1 2. Testing 1 2. Testing. Testing 1 2. Testing 1 2. Testing 1 2. Testing 1 2. Sorry, testing 1 2. Testing 1 2. Right. Great. Okay. And that. Good morning, Luckman. Okay. Por Dios, Joffrey Portillo. Hey,
panel job.
hold on. How you doing, Ike? Oh, okay.
John, can you hear me?
Hey, Ike, how you doing?
Pretty good, John.
Let's have some fun.
Yeah. So I thought we'll show you some few things about what is a present and what is the future of robotics.
Good. That
Tell,
seems to be an area of interest.
yeah, tell
I
me when
actually
you.
I was very interested in that before I got into neurosurgery.
Ah,
I met the Google people that came to Miami with the self-driving car. That was 5 years ago. 5 years ago, they were working on a self-driving car, and look
I
what
wish
happened to
we
that.
can. Yeah, I wish we can get to Google because if we had the funding like they had, we could make something really, path breaking. But then with the companies that we have, one of the problems that I'm facing with is a lot of time as well as difficulty in funding. But what we propose is to really change the world of neurosurgery. We know how to do it. It's just that we have to look for funding and we have to look for the correct people.
Yeah. Well,
Because
I think we get the funding first, then worry about the correct people. But I think the way for us to get funded is through companies, robotic companies. I mean, if you televise how good or you're accurate about the assessment and how it's used, I think once a robotics company sees what we're trying to do, they might sponsor the webcasting. Yeah, that would be a natural for them, obviously. So we'll get it going. Well, if you can get the names of people to talk to and have them watch these webcasts and maybe even suggest where they want to go, where do you want to go with this? But I mean, it's a good way to put their name in front of people. It's a really good way. And we can show them.
Now, there are a few companies involved. For example, I am working right now with Escolab. Now, they are fantastic. There's no question about it. But what I want is the scale is way bigger, which means that what I want is something of a robotic neurosurgical suite where, the investment into research would be in the tune of $1 billion. So
Right.
we're talking about a robotic table, a robotic intraoperative MRI, robotic exoscope, endoscope navigation together, lots of stuff. I mean, lots of tech from defense, aeronautics. So all this has to come together, and it's you cannot do it with limited funding, which most companies cannot afford to do that. They could, but they would not because they don't know about what returns they're going to get on this. So that's the thing. So we need somebody who would do it just because it's cutting edge, path breaking, and it will change the way neurosurgery is all over the world.
Okay, well, they could start small, but certainly this is the way to show the product and the potential of it, and it's real, and that neurosurgeons can ask questions about the product and be taken through. I would think that's a good approach for a company like that, is to get the neurosurgery community to know what the product is, what it can do exactly, and even have some webcasts where you have the reps there taking neurosurgeons through, and they don't have to be big. They can just have 3 or 4 neurosurgeons. That's how it's going to work. It's going to be slow, but you get a couple of converts and you got people that want to talk about it. It's a good way for them to start. You don't have to have 20 neurosurgeons on the webcast, just a couple with the company.
Yeah,
bringing
you're right.
them through. I think I'm seeing it. I'm having webcasts now. I had one last night with a small group. It was great. All these 5 neurosurgeons interacted. You know what I mean? And I thought, wow, this is better than having 100 neurosurgeons. Do you know what I mean?
Yeah, yeah, absolutely.
It's a small group, but I think these companies
Passionate.
will realize that
Yeah, yeah. You
because when
tell
they
me when you
show
want.
it, it's just you, So,
Tell me when you want me to start, and
oh,
I'm all
okay,
ready.
we got 7 minutes. We'll get more people as we go along. So how are things at Kerala?
Karad. This
Right,
place
I'm
is,
sorry.
yeah. So we are slowly. I mean, Abhiram is here. Uh, so he's been there to my center. So we are slowly establishing, as usual, my dream, one of the world's best centers again. So we're having 200 beds for neurosurgery. It's a 1,500
200
bed
beds?
hospital. Yeah,
What?
200 beds for neurosurgery.
My God.
That's big. Yeah, and so we'll have uh, three completely dedicated ICUs. I mean, three completely dedicated ORs, two standby ORs, and we will have literally everything under the sun. So intraoperative CT, we had intraoperative MR before. It's a white elephant. So we decided for a high resolution intraop CT with
Yep.
VR, with navigation, with exoscope, with kinevos, with the lab, with with everything under the sun that you can think of. So this is what we are establishing here. It's a bit of a pain because a lot of responsibility, and it's a charitable trust, so a lot of patience. So I'm trying to find time. I'm trying to find time for my trips, for the academics, for the surgeries, for establishing this thing, and then getting the right team on. So it's been uh, a tough journey over the last couple of years, but it's giving dividends now. It's paying dividends. So the place is coming up amazingly. So
Oh, okay, good. Are the reps, they come to the hospital and they show you how the machine works, et cetera, et cetera, et
yeah,
cetera, right?
yeah. The thing is, most of the things that we are asking for is not anywhere. Many of them are not on the planet, so we got to design them. So, for example,
Okay.
we got this intraoperative CT with VR, and nobody had it before. So we had to go to Germany, sit down with Siemens Health president, and tell him, "See, this is what I want."
Right.
So it took us 6 months, but it's coming right now. So the exoscope. So we're trying to marry the exoscope with the robotic holder and the endoscope. I'll be showing that right now. So the
Yeah,
robotic
that would be
endoscope.
interesting to see for me as a
Yeah. So
non-neurosurgeon. So,
the robotic endoscope holder is not available anywhere in the world. So there is no rep who knows about it. So I had to get a robot, get a company in India, get them to
oh,
design it, and then hold the
wow.
robot.
Wow, you've been with them from the not to start, but almost to start.
So
But yeah, wow, you're marrying two technologies in the OR, two gadgets in the OR. That's who you're marrying, right?
yeah, so this is exactly what we are trying to do. And then right now we are applying for three design patents and five process patents. I realized that before. I mean, earlier I never used to get any patents, but now I understood that we keep on talking to the companies, and we don't sign NDAs or we don't sign patents. And what happens is the companies adopt that technology. They don't tell me, I don't mind that, but they adopt that technology in a way inferior way that I want, in a much way inferior way than I would really want it to be. So I don't have a say in that because the companies would listen to me and then they'll do whatever they want. So I thought we'll patent them. So now in a month or so, the patents would be ready. We are applying for it, and so it would be
Yeah.
ready.
Okay, so I see you're starting from the start. So yeah, let me get to know them. I'd like to meet the people
Yeah.
and do more webcasts with their product. I mean,
With
and we get a
the
wide readership. They may not be
we,
in the panel, but we get a wide readership. You know that.
yes,
Uh,
yes.
and I tell you, What's Up is a great advertising media. It's fantastic. It's even better than Facebook. Uh, and you've been around since the beginning of Facebook. I kind of caught up with it, but I'm seeing What's Up. They made some changes lately that make it really great to advertise. So, anyways, we'll get their product in front of people and trace and watch the evolution of it and how it's developing, and educate the neurosurgical community the
You
benefits
should come
of
to
having
India
the
in
S.
August, John. You should come to India in August. In August, we are inaugurating
Yeah, I
the
might. I'm looking to kind of get out, as everyone is, get out of the shell for a change. I love to do
come.
that.
I remember you being there in 2017. That was almost 5 years back in Biratnagar. And now this institution, when it's ready, I mean, we are inaugurating the lab in Jan, and then the entire institute is going to be inaugurated in August. So we're really looking forward to have the whole world there, and definitely you, because you've been there from the beginning. So we would invite
Okay,
you.
good. We'll talk later privately, and we can start right now, and
Yes, yes, yes.
and I'll get to see what you're talking about. I didn't realize that you were starting with the company and marrying those various technology, exoscope and the robotics in the OR, but I'm looking forward to hearing about it. Okay. Okay, let's start. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett of Neurosurgical TV with a guy that started at the beginning of Neurosurgical TV, Iype Cherian. I even went over to Bharat Nagar to be with Iype and saw how hard he works and how much he teaches and how he's dedicated to the furtherance of the science of neurosurgery. And Iype's going to talk about robotics. I'm looking forward to hearing about it. Welcome, Iype. It's all yours.
Thank you, John. Good old friend. So I would start off with what is robotics, and how much of robotics is being done right now, and what is the future. So I would share my screen right away. Are you seeing my screen?
Yes, not full screen yet.
Is that all right?
Yes, yeah, it's perfect.
Okay. So conventional neurosurgery is in fact 50 years old. We have made some changes to the same things that we've been following over the last 50 years. But these are not paradigm shifts. Paradigm shifts are when the horse carriage changed into a car. Okay. The steam engine changed to maglev. And these are paradigm shifts. In neurosurgery, microscope, when Yasagil was responsible for introducing the microscope, that was a paradigm shift. Micro instruments, drills, CUSA, neuromonitoring, navigation, intraop imaging, these were all paradigm shifts, in fact. But after that, nothing really happened. We are now polishing all these things which has been present for a long time. We've been just polishing them. We trying to find solutions with them without really, changing anything. So that is exactly what I would like to change. The sad fact is most of the ORs in the world, I would say about 3/4 of the ORs in the world, doesn't even have these conventional neurosurgical equipments. I know of so many ORs which doesn't even have a microscope. So we are limited. How can we go past that? This is where we have to develop things in our own countries where the cost is much less. So this is why neurosurgeons, instead of writing papers, they need to be innovators. Okay, they have to use their experience, and they have to be innovators. Another thing I would like to mention, I was just talking to Dr. Chandrasekhar Dupujari today. We all have experience over years. For me, it's vascular skull base and trauma. For somebody, it's spine. For somebody, it's functional. We all have our experience. And what happens is 80% of this experience retires with us, dies with us. We teach it to the young. We teach it to our next generation. But there is no collective information being pooled. There's no collective data, especially, for example, if there's a tumor, I know how much to pull on a tumor. Maybe I may make a mistake, but today, most of the tumors, for example, if I am dissecting a craniopharyngeal tumor from the hypothalamus or from the stalk or from the brainstem, I kind of know how much to pull. When I was younger, I was pulling it harder, and I've had some disasters. Then I started pulling it much lesser, and I've left tumor behind. It happens to everybody, but today I kind of know. I'm not so good at it, but I kind of know how much I can pull. The famous song, The Gambler, they say, you should know, when you gamble, you should know when to run, when to let go, when to play, when to run. So this information is individualized for each neurosurgeon according to his scenario. Can this data be put into a single system? Can this be put into a data set? It can be. That's the beauty of AI. AI and deep learning can help us to put this, if we have simulation, and then we have a lot of surgeons who can help, we can literally put this data into, a giant data system. And this can be the experience of neurosurgeons. And then the next generation will definitely become better, way better, because they have the data sets for a lot of neurosurgeons. You cannot say this is the best, this is the best, that is the best. You see these surgeries must be recorded. I have a company called OPEX Park who go ahead and, they go ahead and they get the unedited recordings. And it's fantastic because you need those recordings, especially from surgeons who are the best on the planet. And those recordings will get you to understand, teach the machine as to what are the steps to be followed. Let me show you some tumors. Let's not bore you. This is a corpus callosal epidermoid. It was engulfing both the A2s. You can see here, both the A2s are being engulfed. So that is a vascular system, and you can see how we are doing this small craniotomy here, very small craniotomy. And that underneath the fox is, this is the interhemispheric approach, very small approach, and you're going ahead and decompressing this tumor. So we're using the exoscope for this. The 3D picture, you can see that's going below the fox there. And we are slowly dissecting it away from both the pericallosal and the callosomarginal arteries after decompression, seeing the other side cingulate gyrus there. So we have a very small interhemispheric corridor. And we are removing this tumor through the interhemispheric corridor. The dissection plane is not the best. Epidermoids sometimes have good planes, but sometimes the planes are a bit fibrosed. So You don't have the best of planes, but we are trying to make it the best of planes. So slowly, gently, without any bleeding. You should not have any bleeding in an epidermoid. So if there is any problem, you leave a little bit and crush the origin. Instead of trying to pull it, you can just crush it and dissect it. It's keeping on, taking it out, taking it out. It's a dirty, pearly tumor. So the exoscope is beautiful. I mean, the point lock system is excellent to get into the different angles, and the ergonomics is just brilliant. So keeping on, taking it out, identifying the pericallosals, the callosomarginals, the arachnoid of these vessels, the corpus callosum, see the point lock, how the angles are changing. You just have to sit down there and use the point lock, and you can keep. So you can see the pericallosals there, dissecting it off, the pericallosals. The corpus callosum is completely deformed. So it's bending inwards. So you need to understand that the pericallosals, they follow the corpus callosum. So you got to take where the tumor is bending in. You need to take that part off for complete clearance. Crush it, and rather than pulling it, crushing it. That's the way to go. So, even this tool, robotic tool, just for the crushing part, I mean, even a mechanical tool for the crushing part with a robotic positioning tool where, I can position these tool with my hand in a very precise way, would be really appreciated, You can see now I'm going to the ipsilateral pericallosal. See the ipsilateral pericallosal is there. So between that, the tumor is dipping in. So I'm keeping a patty on the pericallosal and dissecting it off the corpus callosal roof. Delivering it out gently. Now we need to go with an endoscope. This is a 30-degree scope with a robotic holder. So we have the robotic holder. You can see on the exoscope, the scope going in. This is a 30-degree scope. And what you cannot see, this tumor you cannot see here, but you can see the tumor here. You see with the 30-degree endoscope, you can see under the fox, on the cingulate gyrus and under the fox. You can see the scope going in, and I'm going to dissect this tumor with the endoscope assistance. And this endoscope is being held by my robotic holder in place. So with the exoscope, you cannot see. You can notice that what I am doing is right. I cannot see it with the exoscope. Even with the point lock and at very steep angles, I cannot see it. But with the 30-degree scope in there, I can really see it. And I'm dissecting it off the cingulate, contralateral cingulate. And I'm taking it off. This is truly endoscope assisted exoscope surgery. And for that, you have the robotic scope holder. Now you can see if there is anything. There's nothing there. You can see the corpus callosal roof where it is bent in, and you can see the ventricle there. every bit of tumor, the two pericallosal arteries you can see, and you can see how small a craniotomy is being done. The entire tumor has been removed. What I wanted to see is the setting, the operative OR setting. And hopefully I'll be showing you that. See, that's the exoscope. You can see the robotic exoscope, the AOS, one of the best scopes. We've seen everything, but it's one of the best scopes. And that is my endoscope holder. So the neuropilot mated to that is my endoscope holder. This is something that we designed. So this is the Franca Amica robot holding the endoscope. And so you can see the exoscope on one side, the endoscope on the other side, and this is how we are operating. So this is our residents. I mean, this is our fellows team, and this is our consultant, Dr. Hari Giacomo from Italy, Edmundo from Peru. We have Tamerlan from Russia, who's missing. He's gone for his tooth job or something in Kyrgyzstan. And we have Nargiza here. We have Ranjit, who's a PhD in neurosciences. He's following AI, machine vision, deep learning. So this is what we are looking at. So we will show you an overview of what we've been doing. This is an STMC anastomosis with very high magnification, 80 to 100 magnification. So this is something that we do. This is a modified Dollings and ACOM, I mean, IC bifurcation aneurysm. In fact, an IC aneurysm clipping. So that's aneurysm being clipped. We have the ICG in there. This is a ACOM aneurysm being clipped. I'll show you the detail. This is the contralateral A2. I mean, ipsilateral A2, contralateral A2, contralateral A1, ipsilateral A1, and that's aneurysm, very poor grade aneurysm, clipped. That is the clipping. So all using the exoscope. This is another epidermoid, which is going into the interpeduncular cistern all the way from the temporal, suprasellar, everywhere. So we are clearing it out. This is, we showed you the exoscope, endoscope combined technique. This is the exoscope that we have. This is the robotic endoscopic holder that we have, demonstrating it to my very good friend Charlie Teo and my OR. This is how the endoscopic holder is in action. We're doing a transclival route to the brainstem, to an exophytic brainstem tumor. That's my colleague, Dr. Vinod Felix, my ENT colleague. Sajeev Vadakadam is seen. I am here. So you can see how we're using the exoscope for removal of a tumor, how we're using the endoscope holder for removal with side-by-side exoscope endoscope assistance. You can see how the OR setting is. That's a Franca Amica robot holding the neuropilot of the endoscope and attached to that neuropilot attached to the endoscope. And of course, the exoscope is outside. So this is what we are doing. And things not considered usually. I mean, this is what we are looking at. And the recent advances, the table is never advanced really. So we are looking at a different table, different headrest, different handrest. So already we have a handrest made for us. And it's fantastic. So it helps you in a lot of ways. It helps you to completely take your It's movable in any way you want. It can take a lot of weight, so you can literally stand on it. You can hang on it, no problem. So, and it can go to any different ways. It's a hydraulic, so you can set it in any different way, which with least amount of pressure. It's based on something called the Fortis Tremano, which is from Mackay Gettinger, who's doing our theater. Then we're working on a surgeon's chair, which can be married to all the instruments that you need to do, that you need to have. We're looking at new tools like laser. We already have operated with laser in a few tumors. Tumor tunneler, mechanical QSA, the exoscope, augmented reality and mixed reality in theater, and robotic tools. These are what we are working on right now. Without the patents on, with the NDAs on, I cannot be telling you details, but I want you to think. Okay, what I want you to do is to think and innovate yourself. And what is the setting at Krishna right now? We are installing the 192 slice interoperative CT on rails with VR. We already have the AOS robotic exoscope, the Kinevo 3D microscope. We have the navigation systems. We have the Franca robotic endoscope holder. We have the Einstein Vision 3D high fidelity endoscopes, as well as the scopes for assisting the exoscope, that is the Pernesky scopes, the intraventricular scope, and the transnasal scopes. We also have 200 beds or 50 beds for ICU for neurosurgery. It's a charitable institution. But of course, we have paying patients too. So we have critical care and neuroanesthesia teams and rehabilitation facilities. So we're trying to make one of the best places on the planet with the best infrastructure, and bringing the best to the needy and the poor without really differentiating. What's the future? Now, we think there will be better intraoperative real-time imaging coupled to digital real-time vision, integrated exoscope endoscopes, navigation neuromonitoring, navigation coupled to AI as well as deep learning, and combining a personalized atlas to each patient. Robotic surgical arms with new tools like laser, tumor tunneler, plasma knives, endovascular robots. Magellan is already there. Siemens is acquired it, but there's a lot of changes that needs to be made to this. Complete neurosurgical suite with robotized table, chair, handrest, ergonomically arranged tools, different perspectives to tumors, vascular work, spine, trauma, functional, and of course, for the future, critics for any new advances who will never be willing to change. I mean, as I have seen, whenever you make new advances, there would be people who say, oh, we're fine with the old thing, we don't want to change. And every innovator would face that for the rest of his life, because, if there are people who will extol the beauty of the present and who would say the future is bleak because you're changing it. And, these are the guys who will inspire you to go forward, who will, hate you, who would throw stones at you, but this is why you will go forward. If nobody was throwing stones, you'd be less inspired to go forward. So these critics would be the ones, they would be the older generation. Generally, they will not be the newer generation. They'll be the older generation who are in their comfort zones and who will resist any change that will happen. So of course, you cannot have nonsense as well. So they have to be there. It's very important that they are there. So thank you very much. I hope if there are any questions, please go ahead and ask me.
Hey, thank you, Iype. I'm sure this is the one of many webcasts that we'll do about what you're talking about. I'm not a neurosurgeon. I don't totally understand it. But I can see that it's going to take some work. And you have some robotics equipment obviously installed in your hospital, correct?
Yes, I already have it.
Go ahead.
I can see Kenji here, so he may have a lot to say as well. So
yeah, okay.
Dr. Kenji Ohata, would you like to say something about sharing the skills that we achieve in a lifetime. So for example, your skills in skull base, somebody else's skills in vascular, and other people's skills. So that it is very important that we can get it into a data set and then start sharing it. So this data set can be measured, and then you can go ahead and um, install it into a robot, so that the robot, when it operates, it knows, I mean, it has the experience of different surgeons. Easier said than done, but it's possible. Dr. Kenji, would you like to say something?
Yeah, so thank you for inviting me to this discussion. I am staying at home. My family is with me. Anyway, so thank you for your good talking about robotic surgery. I'm wondering the definition of the robotics. If there is an arm and there is a joint, we may call it a robot or something like that. Anyway, we need such kind of instrument or some system. The one of the problem is rigidity of the instrument. Keyhole surgery becomes the space getting small. We need a very small system, small scissors, small bipolar system. But titanium may be too weak to perform such kind of robotic surgery. I hope India will develop such kind of good instruments. Because you have many companies in your country.
We are trying our level best to collaborate with companies around, because right now I am collaborating with Escolab for the AEOS digital surgical cockpit. So that involves both visualization devices and surgical robotic devices. But India, it's not very easy. We have seen a company, Delhi-based company. We are looking forward to. They have developed a robot already as a alternative to Da Vinci, but we don't know. We haven't really interacted with them, so we don't know what is their capability. So once we look at these companies, yes, we think neurosurgery will change once we have these tools.
So now venture capital of Japanese country moved to the India. So you have a very so large population. I think you are so young. So I hope you develop such kind of robotic system with your friend in your country. Thank you for inviting me to this discussion.
So much. It's an honor to have you here.
Like, are there other institutions, who's at the head of the pack as far as developing robotics in neurosurgery? Is there like Jefferson University, or what? Is there one center that is kind of leading with the use of robotics? Are you familiar with any?
John, a lot of people are developing robotics in surgery. Da Vinci was around from 1995. And if you look at NeuroArm, Garnet, who's my very, very close friend, Garnet has been doing NeuroArm 1, NeuroArm 2, and NeuroArm 3. But, and in many other countries are also, Da Vinci has been, they have tried to use Da Vinci for neurosurgery also. But as Dr. Kenji said, it's a big challenge to have very small instruments. The only thing is we have to think outside bipolar. So right now we're looking at plasma knives, we're looking at holmium and thulium lasers. Instead of bipolar, we're trying to look at that. And these are very small fibers which can be passed through very, very small holes, So instead of we are looking at something called the tumor tunneler. It's a very small thing where it's a powerful suction and, it's a screw. So it rotates inside. So once you cook the tumor, you can tunnel and take the tumor out. And you can define in 3D space as to how much tumor should be cooked and how much should be taken out. Now, these are all things which are concepts, which I don't know how much of it can be practical. So we have to use the old school of experience. Like, for example, Kenji has so much experience, and we have to use that, and we have to use technology to make it better and accessible to others as well. So that is robotics. Robotics is once robotic comes, it's just not Kenji, or it's just not Lawton, or it's just not somebody doing some surgery. Robotics means it will be universalized. People can, the robot will know the protocols and what to do, where to do. For example, if there's a petroclival meningioma, right now, the results with petroclival meningioma for many people who are not doing skull base, it's dismal. But imagine we're able to do a small subtemporal approach, do just enough drilling, and keep a 1 millimeter shell of the tumor and take out everything in less than 10 minutes with the robot. And the patient comes that day and goes home that day. That is something which will change neurosurgery, especially for this kind of tumors. That applies to everything. So this is what we're trying to change.
I think probably the field that's most advanced in the use of robotics in medicine is urology. They've been using it for a long time, and I think almost as treatment of choice for a lot of things is robotic treatment of. But of course, I don't know if they need such fine instruments that neurosurgery would use. But
Yeah,
it's hard, even in heart surgery, they use robotics to do surgery. So that I think that's pretty more advanced, of course, in neurosurgery.
Thing is, margin of error in neurosurgery is way less. So in urology or laparoscopy, these instruments can be big. So for example, we are doing an STMC, a very small STMC. When I'm doing it, we are anastomosing a 0.7 to a 0.6 millimeter vessel. And we're doing it with an exoscope at a magnification of about 80. That's what I was showing you. I don't think any robot right now can do it. I don't think there's any robot which can do it. So we need to have a robot that can do that kind of stuff. So it's not easy, but of course there's a way. If you bring aeronautics and defense, into neurosurgery, then maybe we can.
Okay, I think we have Dr. Al
McCarthy wanted to.
Affleck, can you talk, please? Unmute yourself.
Yeah, hello. Guten Tag. Mchlafi, I'm from Germany. I'd like just to have something. Professor, it was amazing. And it's very nice to have you here always. I have just one thought. I'm seeing that we still have a problem to think about our point of view of whole keyhole surgery and robotic and so on. We are still in this trap. We are still hanging. We are always still having discussion how big is our craniotomy, how small is our craniotomy. I'm personally going to think why we have done that because of trauma, because of the post-operative but we are now so advanced. The people are taking the heart back, and we are still just trapped in this way. That's why I'm talking about the keyhole. I'm going to think it just mind. We have this tension, and we have a goal to share, but we don't have this way, the old way, to cut the skin, make a craniotomy, and to go. And how I'm going to push, how I'm going to this make what we still making problem for ourselves in a way, in this technique, because we have something to review. Then we have also to think. Sometimes we have right now the keyhole as standard. But it's bring a lot of problem with instrument, with. Why we're going not to refuse, start the beginning. Why, what is the problem to get bigger crani to make something more advanced and more beautiful and easier?
Yeah.
Very strong post-operative ICUs. We have a very big and good post-operative management. Well, in the past, it was really a discussion. This so big craniotomy going to have a side effect of radiation. We are still in this sport.
Yeah, so I can answer your question. I understand your question. So, see, Al-Maklafi, it is a journey. So it is a journey, which means, we learn yoga. And the first thing that we learn in yoga, they are simple asanas. You cannot be doing a very complex asana on the first day. It's impossible. You cannot even think that you can do it, because when your teacher does it, you think this is almost impossible. But as you progress in years with asanas, then you can think about standing on a single handstand, or completely contorting your body and things like that. Now, it is not right for the beginning person to start off the complex asana. It's completely not right. If there is no teacher available, or if there is no facilities, if the patient, the person doing the yoga is not physically fit enough to do that kind of an asana, you should not do it. So the point is, it's a journey with many factors. So when I started off my skull base, when I started doing Dolench or Kawase approaches, we were doing large craniotomies. I mean, huge craniotomies. And as you said, I always wanted to do it because I was comfortable doing that way. But as the years passed and we had our failures, we had our success, the sizes came down, and now we are comfortable with that size. So I'm not asking anybody to be comfortable with that size. It's my journey. Your journey is different. So the point is, your objective is to get smaller and smaller. When you can achieve something, the same thing with a smaller incision, why go for a bigger incision? It doesn't mean that you have to put in only smaller incision and this is the standard. If you can achieve something with a bigger incision, by all means, go ahead and put in the bigger incision, and you get comfortable with the bigger incision. And after that, you must know that it is also possible. When I remember 10 years back, when Charlie, my good friend, he told me that, he can take out gliomas with an incision like this, small coin-sized incision. And I used to tell him, no, Charlie, you're crazy. But today I'm using the same incision as Charlie is using. We doing a glioma tomorrow, and my incision is not more than 2.5 centimeters. Okay. So this is how you get comfortable with stuff. And this is your journey. And maybe day after, maybe tomorrow, if I feel that I'm comfortable with a bigger incision, I'm having higher rate of complications with smaller incisions. Obviously, I'm not going to be following a smaller incision.
Professor.
Yeah. Hello.
I don't speak about the normal, what we are doing. Yeah. Can you hear me?
Yeah, I can hear you.
Yes.
Hello?
Yeah, I can hear you.
Hello?
Yes, I can hear you.
So, Professor, I'm don't speak about normal neurosurgery, what we are now doing, what for the skull base or I'm thinking about the future. I don't have a problem with an glioma with just a big hole with some 2 centimeters or something. That's not the case. I'm thinking about if we would like to make a future So it's not what we are doing now, but in the future. So we don't have to put some stones in our way. That's what I'm talking about. I mean,
Yeah, I understand.
for the future. But now let's do it smaller and smaller and smaller. Even we have a microscope and we have to better microscope. Let's do it smaller and smaller and smaller. Even if that's the way. I like the way to have a third eye with the cystoscope. That's a very nice one. But I mean about the future, about thinking in the future and planning in the future. Some stones we are putting in our way ourselves.
I understand. See, the future is not linear. That's what you have to understand. The future is never linear. So a microscope was a paradigm shift. When Edison invented a light bulb, it had no relation with the candle. So the future will be something I'm calling it hypervision. Hypervision is a fusion of exoscope, endoscope, VR, mixed reality, AI, and Atlas, everything together. That is the future. That is the future vision. The future tools are lasers. I mean, maybe microwaves, maybe intravascular devices for tumor embolization, intravascular devices for aneurysm embolization, stem cell therapy, genes. This is the future. It's not non-linear. That is what we have to understand. We always think about the future as a linear add-on. It's not true. So if you come outside the box and think, every way that you go to your home, you cannot think that the way to your home has to be straight. Sometimes there will be a sharp bend and you have to take that sharp bend. So you have to understand that the future is non-linear. So you have to think outside the box, and when you are not able to solve something to the maximum, when you're not comfortable, you have to take a bend. So this is something as youngsters that you should learn. That is all I'm saying.
Thank you very much.
Yeah. Abhiram, you would like to say something?
Sir, good evening, sir.
Yes.
Good evening.
Nice to have you here.
Tell me, Abhiram, you're doing great work in your institute. You're doing fantastic work, and we hope to see you in January for the meeting.
Yes, sir, definitely I'll be coming there. Nothing like great work, and also I'm just doing the work what you all have been doing, just following your footsteps.
Thank you very much.
I'm really interested in this AI and VR fusion, sir, because that is what is the future. If we can see the tumor, its characteristics and its relation with the major vessels, surgery is definitely going to be easy, and also we can perform it in less time. So I'm looking forward for it.
Yeah. So we are developing it right now. So maybe the prototype will be available in 1.5 years. We should be getting the prototype. Only problem with me, my problem is that it's too costly. So I need to bring something which is much less costlier. So I'm trying for that. Let us see what happens.
Okay, sir. One more question is, what is the difference between intraoperative MRI and intraoperative CT? Why you doesn't prefer MRI? Why you prefer CT more than intraoperative MRI?
Yeah, from 2017 to 2020, for 4 years, I had an intraoperative 3 Tesla MR. And believe me, it is more of a white elephant. Actually, it's a wastage of time, if you ask me. Maybe because I'm not more of a glamour surgeon. I'm more of a skull base and vascular guy. So it was a waste for me. I had it in my center. And I'm sorry, but I really didn't. I mean, we used it for a few pituitaries, some gliomas. Even for the gliomas, it was not so great. So there was not much use for the intraop MR. We had a Siemens 3 Tesla intraop MR during that time. But right now, after having looked at Albert Sufianov's center, where he has this intraoperative CT, we have this 192 slides on the rails interop CT, which will take about 4.5 minutes for the entire thing, for it to come, take the CT and go back and reconstruct it into VR cinematic, using the cinematic rendering software. We'll reconstruct it into a VR image and you can see exactly, and then navigate on that. So with that kind of setup, I am hoping, I really don't know, because we are installing it right now. By January, it should be ready. And I can only tell you the difference after I have experienced both. Intraoperative MR for that kind of cost is a sham. It's a white elephant. Intraop CT, I hope, would be much more useful. For example, I went into a tumor and I think I have completely done the tumor. I put in the endoscopes, everything, and I look and I think there is some gray area. There's a lot of blood and there's some tissue and I'm not sure. And I go ahead and then take a CT. It's so clear that it's tumor. So maybe it's because my interpretation of MR, my radiologist's interpretation of MR is also not very clear. This is another thing. So, but for me, intraop CT, a high resolution intraop CT combined to the pre-op MR is a much better solution. We are looking at USG as well. So ultrasound also, 4D ultrasound would be also a fantastic tool. So this is what I think.
That is what I was just about to ask. So will 3D navigated ultrasound add to this?
Yes, very much. So we are looking at it right now. We are definitely looking at it right now. Sonovant was a company which came and then went off. We were very interested, but now there is this 4D ultrasounds and they are brilliant, I hear. So we're trying to get
Medical. I saw one ultrasound with BK Medicals.
We're getting it. We are getting it along with Siemens. Along with the Siemens CT, we are getting the bigger. They are very useful. One thing for me, they are very useful in cavernomas, in especially brainstem cavernomas. What we do is we put in a small patty and we know the entry point. In brainstem cavernomas, one of the major problems is the entry point. If you screw up with the entry point, you have a big problem. So even with the navigation there, you can create problems. So if you put in a small patty and then you do an ultrasound with that finger probe, with that very small probe, you're getting an excellent entry point assessment. This is what ultrasound can help you. Maybe we can change it. We can modify it into something with a robotic holder, much smaller probe, maybe much powerful systems and much more better way of interpreting the data that is being, that is being got. So if you can interpret it in a much better way in the spatial, better spatial resolution and combine it with the CT or the MR, we are looking at a powerful, very powerful tool.
Okay. Looking forward for this and for the January course.
Yeah. We are looking forward to having you here.
Thank you.
Okay, any more comments, questions from the panelists? Kenji, any parting comments? Okay.
I'm happy to see my brother also here. So he's...
Yeah, I was going to ask him. I didn't want to put him on the spot. You want to say hi to Iype, George, on the camera or after? We can wait till after if you'd like. But
it is great to see this. I have also told my friends in Geo Institute, because see, we are actually kind of I'm part of Reliance, and we are also actively interested in doing anything that kind of improves so have societal value and improve and we are willing to collaborate and with the robotics team and all that stuff. So I have more to come on this. I have already talked to my few leaders. The chief operating officer gave me a node today. I wanted to kind of introduce this. Iype, may I request you to also please plan a talk at Geo Talks or Geo Institute in one of these days, and then we will kind of see how to collaborate with scientists to kind of get some things that is and we are very keen to. We're working with Reliance Foundation hospitals and few other places, so it will be great to have you here.
Yeah, thank you, Ranjit.
yeah, a good way to connect these different places is through Zoom. to try to bring this robotic neurosurgery family together. And we look forward to doing more webcast. We'll talk about that later, Iype, about what broadcasts you'd like to do with robotics. It's what you've done so far and where you and the company hopes to go. So we'll talk about that later. And Iype, I think this video is going to make YouTube history. Your daughter's in the background dancing. Is that Yoko? Is that
No,
Yoko?
it's Antoina.
She loves the
She's,
camera. Most kids are shy. They run, but she loves the camera.
She is a big star. She's got a rap followers and all that. She does this rap and stuff. So she's
Okay, say
she's
hello.
big on
Hello.
that.
What's your name? What's your
Hey,
name? Nice to meet you. Do you have any questions?
Crush.
no, she was asking any questions, not crush.
Okay. Okay, thank you
One
very much.
question.
Go ahead.
How do you like the skull out?
No, you don't take the skull out, darling. I'll
Okay,
tell you.
we'll talk about that later. Okay, Iype, hang around. We'll network. Okay, we're gonna end the broadcast, official broadcast right now. Thank you for coming.
See you guys.